off. Good afternoon and welcome everyone to the first Fireside Chat of 2025. I'm Amna Hussein, the Community Outreach and Engagement Manager at the Masonic Cancer Center, and I will be your moderator today. So the Fireside Chats are brought to you by the Office of Community Outreach and Engagement at the Masonic Cancer Center at the University of Minnesota. The Office of Community Outreach and Engagement serves as a vital bridge between the Cancer Center and communities across Minnesota and beyond. Our dedicated team is committed to reducing the burden of cancer by actively engaging communities and providing access to relevant knowledge on the latest in cancer research, prevention strategies, the importance of screening and early detection, treatment options, survivorship, and opportunities for clinical research. As we mark Cervical Cancer Awareness Month this January, today's Fireside Chat focuses on addressing barriers to cervical cancer prevention, early diagnosis, and treatment. We'll explore innovative strategies and collaborative efforts to overcome these challenges and improve equitable access to care. So to guide us through this important discussion, we are privileged to have Dr. Meredith Wise as our speaker today. Dr. Wise completed medical school at Baylor College of Medicine and her residency in OBGYN at the University of Minnesota. She then pursued a research fellowship that included earning a master's in clinical research and worked as a general OBGYN at the University of North Carolina. Dr. Wise is deeply committed to meeting patients where they are, ensuring they have a thorough understanding of their health and creating tailored plans to help them achieve their health goals. Dr. Wise's research focuses on identifying barriers to prevention, early diagnosis, and treatment of gynecologic cancers, with a particular emphasis on targeting these barriers to reduce disparities in cancer outcomes. Her work is an inspiring example of how research and clinical care can intersect to drive meaningful change. So before we dive into her presentation, I'll cover just a few quick housekeeping items. So today's Fireside Chat is recorded, as they always are, and we will post the recording to the Masonic Cancer Center's YouTube page by next week. For all University of Minnesota employees and spouses participating in the university's Employee Wellbeing Program, you can earn 200 wellbeing points by completing the form that will be linked in the chat shortly. And throughout the presentation today, please use the Q&A feature at the bottom of your Zoom screen to submit any questions or comments that you have. We have time carved out at the end for a Q&A session with Dr. Wise. And all right, without any further ado, the virtual floor is all yours, Dr. Wise.
Hey, thank you. I'm going to share my screen, and then we'll start this PowerPoint. Does that look right?
Yep, looks good.
Okay. So thank you for that introduction. I'm Meredith Wise. I practice general OBGYN at the University of Minnesota Medical Center in the clinic on the West Bank. I am a general OBGYN, so not a cancer doctor, but a lot of my practice is in helping patients prevent gynecologic cancers, and I do a lot of the diagnosing of gynecologic cancers before we send them on, send those patients on to the cancer doctors. And I got interested in doing research in this area because I saw a big gap in what I knew as a provider when I was training during my residency, and what I felt like patients knew. And so I've become really passionate about public education, patient education, making sure that providers are up to date on a lot of the gynecologic cancer screening and diagnosis techniques, and a lot of my research centers around the best ways to make sure everyone is getting the most up-to-date care and to improve that care to be more cutting edge, more patient-centered, and fill the gaps that we still have in preventing and diagnosing these cancers. So today our focus is on cervical cancer, and I just wanted to do a quick anatomy review. The cervix is right here. It is the canal that connects the vagina to the uterus, and this is kind of just starting from the beginning. Why I bring this up is because there are techniques to screen for cervix cancer that are part of routine preventative care, and we'll get to that, and that's our focus for today. But just to highlight that There are also cancers that can be in the ovaries, the fallopian tube, the uterus here, the lining of the uterus, or the wall of the uterus, that are very different from cervical cancer and are not part of routine screening or preventative care. And then just another view here. This is looking from the outside. Sorry. And this is the opening to the vagina. You can't see the cervix in this picture because it's at the very top of the vagina, right here. There are also cancers of the vulva and the vagina that are more similar in their risk factors and kind of how they come to be compared to the cervix, but they're also not exactly screened for in the same way. So today we're focusing on the cervix because it's Cervical Cancer Awareness Month, and because the cervix, more than any other gynecologic organ, has really highly proven and highly effective ways to prevent cervical cancer and to screen for cervical cancer. So just some quick facts on cervical cancer. In the United States, it's the third most common gynecologic cancer. There were 12,000 new cases of cervical cancer in each of the last few years, and about 4,000 US women will die from this disease. Worldwide, it's actually much more common than in the United States, and it's a high cause of cancer morbidity or problems or complications from cancer and cancer deaths. What are the risk factors for cervical cancer? So human papillomavirus, or HPV, causes almost all cases of cervical cancers. The statistic that I found when I was putting together this presentation is that HPV causes 99.7% of cervical cancers. So it is basically a prerequisite to developing cervical cancer. HPV is a virus that can cause damage to cells and cause them to mutate into cancerous cells. HPV is extremely common. It's passed through sexual contact, and up to 75%, or 3 out of 4 people who have sex, will get genital HPV at some point in their life. Even though HPV is extremely common, the vast majority of people who have or have had HPV at some point do not go on to develop cervical cancer. Kind of the other thing that HPV can cause is genital warts, but again, just because you have HPV does not mean that you will get warts. Most of the time, HPV, like other viruses that humans get, goes away with time and a normal immune system. So some of the other things that we consider risk factors for cervical cancer are really things that can get in the way of HPV going away with your normal immune system. So the first one is smoking. So smoking can make it harder for your body to clear the HPV, and anything that depresses your immune system, like HIV or immune system medication. So people who have had transplants or who have immune system diseases, one of the common ones are like rheumatoid arthritis or multiple sclerosis. These people take medications that can depress their immune system, and that makes it harder for the body to clear HPV. So in terms of preventing cervical cancer, the biggest thing is preventing HPV. That's what we call, when we think about cancer, we think about 2 layers of prevention. There's primary prevention, which is preventing it entirely, and there's secondary prevention, which is catching it early or catching precursors to cancer. So the most important thing in preventing cervical cancer is the HPV vaccination. That's been available since the mid-2000s and has become part of the normal childhood vaccine schedule. And ideally, the HPV vaccination will take place before the onset of sexual activity. So that's why it's scheduled for the ages of 11 to 12, hoping to catch most people before they initiate any sexual activity. The kind of normal range for it is 9 to 26, but it's also approved for up to age 45. I think that the majority of people in their 30s probably were eligible when it came on the market when they were teenagers, but there are probably still some people in their early 40s or late 30s who did not get it when they were a teenager or preteen and are still eligible for it now. I mentioned before that HPV is sexually transmitted. As opposed to most other sexually transmitted infections like chlamydia and gonorrhea and even HIV, condoms aren't super effective at preventing the transmission of HPV. They can offer some protection, but a lot of that transmission doesn't come only through penetration, but can live on the skin around the penis and a vagina. And so that's why condoms aren't as good at preventing HPV spread as they are at preventing the spread of other sexually transmitted infections. So now that HPV vaccination is becoming more prevalent, a lot of people ask if they still need to get cervical cancer screening, which is that secondary prevention or the next layer of preventing disease from cervical cancer. And the answer is yes. And the main reason is because the HPV vaccination, the one that's being given now covers 9 strains of HPV, but there's actually a lot more strains than that. It covers the ones that most commonly lead to cervical cancer and the 2 strains that most commonly lead to warts. But there are other strains of HPV that the vaccine doesn't cause, and even with vaccination, sometimes people can still get the strains that the vaccine does cover. So it is important to get your routine cervical cancer screening, and we'll go into that in a couple of slides. If that screening leads to any precancers, the diagnosis of precancers, it's important to get that treated as well. And then if you have an abnormal screening test, that usually means you need more frequent screening or frequent follow-up testing, and that's another important piece. So cervical cancer symptoms, it's very often not symptomatic, and very often diagnosed with the screening test. But sometimes irregular or heavy vaginal bleeding can be a sign of cervical cancer. It usually isn't cervical cancer. It can also be uterine cancer, but way more often it's not cancer at all. But irregular or heavy vaginal bleeding can be a symptom of cervical cancer and should always be evaluated. Bleeding after sex is something that's a little more specific to cervical cancer, but still most of the time it's not. So these symptoms are neither very common in cervical cancer, or they're also common in a lot of other things. So it's not a slam dunk that you have these symptoms with cervical cancer or that you have cervical cancer if you have these symptoms, but they're important things to get evaluated. Watery or mucousy or discharge that smells bad can also be symptoms of cervical cancer. So we talked about the importance of screening because most often cervical cancer can be prevented if precursors or precancers are caught and diagnosed. And otherwise, cervical cancer is often diagnosed early via the screening tests when it's easier to treat. So when should people get screened for cervical cancer? These recommendations, depending on how old you are, they have changed numerous times over my lifetime, over your lifetime. I often have patients they think they need screening and they don't, or they don't realize that they're due for screening. So it's just important to bring this up at your routine preventative care visits, which you should be getting at least every couple of years, if not every year. Pap smears at one time were annual, but they're not anymore. and we'll talk a little bit more about that. So cervical cancer screening should start at the age of 21. This is regardless of HPV vaccination status, like I said before. It's also regardless of sexual activity. And the main reason for that is because there's still, even though HPV is sexually transmitted, it doesn't require penetrative intercourse to pass it along, like I said before. And right now the recommendations are just uniform regardless of sexual status. And screening should occur every 3 to 5 years, and that kind of depends on your age and what kind of testing that you're getting. The exception to that is if you have HIV or on immune system suppressing medications. We talked about how those can make it harder to clear HPV. So you actually need several negative tests before you can move on to the schedule that everyone else is on. But that's kind of a unique situation, so we just recommend talking to your specific doctor about that. And, cancer screening tests are important because they look for early signs of cancer in people who don't have symptoms. And in the United States, there are different organizations that recommend cancer screenings as part of your preventative or routine care. These organizations include the United States Preventative Services Task Force. They recommend a lot of the cancer screening, like colon cancer screening, cervical cancer screening, breast cancer screening, and other things like diabetes or high cholesterol screening. The American Cancer Society also has guidelines on cancer screening. So those are the guidelines that your provider should be following when they are setting the schedule and picking the test for screening for cancers. So what kind of tests do we use for cervical cancer? This is the infamous Pap smear, or Pap test, as we like to call it. It has been around for a long time. It is kind of notorious in the for patients with cervixes that they have to get their routine Pap test. More recently, HPV testing has come into play, so that can be run. When it was first introduced, it's run off the same sample that's collected at the time of PAP. So when we do the PAP tests, we both look at the cells and do DNA testing on that sample, which can test positive for different strains of HPV. So oftentimes we're doing a combination of that. So what does that look like? This is the speculum here. So the speculum goes inside the vagina to give your provider a view of the cervix. And then either some sort of spatula or a brush collects cells from this area of the cervix because this is where the cell type changes, and that's where HPV can cause the most damage. So we get a specimen from the junction of the internal cells of the cervix and the external cells of the cervix. And then we can use that sample here to run HPV, and the cells also get smeared. That's why it's called a Pap smear onto a slide that is then examined carefully under the microscope. So some of the newer developments in cervical cancer screening are HPV self-collection. So these are self-tests. They're swabs, kind of like skinny Q-tips that patients can place in the vagina themselves. It does not require a speculum or a pelvic exam. Can be done in the exam room or the bathroom, and is ideally a little bit more has less discomfort associated with it. So there were a couple of these tests that were recently approved by the FDA back this past May. Some caveats to that is that they must be done in a healthcare setting, and that's just because of lab stability, and they're done at the time of a visit so that the appropriate follow-up happens after them. But there is more to come in that arena. So your provider's office may or may not have these yet. They're kind of rolling out. So they may not be part of the care that you're offered in your at the practice that you get your preventative care at or your gynecologist's office, but you can call and you can ask if they are going to have them soon or what they're thinking and if that's going to be part of their care. Um, it's not yet approved under any of the national organization guidelines that self-collection can be done, but that is also in the process of changing. The U.S. Preventative Services Task Force has their cervical cancer screening guidelines under review to include self-collection as a valid option for screening. So this is a picture of what some of those swabs look like, and this is a diagram of how that's collected. So this would be provided when you do that self-swab. So how about HPV testing at home? There are some tests in development for this. I know that this is, at least in my social media bubble, is gaining a little bit of traction. Right now, these are not FDA approved, so they're not recommended. And some of the reasons why these aren't being fully rolled out yet is because mailing it in, it doesn't leave some room for the test to become invalid because mailing it isn't as controlled or bringing it into an office. It's also cervical cancer screening. It's not something that has to be done outside of certain intervals. So it's not recommended that people just go to the store and buy this, every year or every 6 months or anything like that. So we are trying to come up with really innovative ways to make cervical cancer or screening more accessible and more comfortable and bridge that gap between those who are up to date and those who aren't. But right now, HPV testing at home isn't officially condoned yet. Still in the works, though. Curious to see how that develops. So what happens after an abnormal test? Does an abnormal PAP or HPV test mean you have cancer? Absolutely not. The vast majority of the time, it doesn't, but it does mean that you need further testing. So what I use to determine that is the American Society for Colposcopy and Cervical Cancer Prevention, and their guidelines, which are based on the risk of cervical precancer. So cervical precancer has a higher risk of developing into cervical cancer. So we recommend treatment if you have cervical precancer. And they have these algorithms that are on this app that help us determine based on the results of your HPV test and or PAP if you need further treatment or further diagnosis. And that the next step after a pap smear is often a procedure called a colposcopy, which is where we take a really close look at the cervix under the microscope, and we actually use some vinegar and some other solutions that help highlight those abnormal cells that may have been picked up on your pap or that may be there because of the result of HPV that you tested positive for. And we can take biopsies, and rather than just the HPV DNA or just the cells that get smeared at the time of a PAP, it's a little bit bigger piece of the cervix, still really small, like a little bit bigger than the tip of a ballpoint pen. But that can be looked at under the microscope to determine if there is any cancer. And sometimes we remove a small part of the cervix if there is a precancer. Okay, and then do we need to get PAPs or HPV tests for the rest of our lives, or is there a time that we can stop cervical cancer screening? And the recommendation is to stop screening at age 65 or after hysterectomy if the cervix was removed. So if you're having your uterus removed, that is a hysterectomy. You can also have the cervix removed, the tubes removed, or the ovaries removed. So it's very important that you know which organs are being removed and which ones are left, because you can have a hysterectomy and still need pap smears or HPV testing, cervical cancer screening, or you may be done. The caveat to stopping at these times is if you've had many years of normal and adequate testing. So if you are over 65 or if you've had a hysterectomy, but you may not have had all of your cervical cancer screening, or you have had abnormal cervical cancer screening, you may still need to get cervical cancer screening after 65. We can also do PAPs and HPV tests of the vagina if you don't have a cervix anymore, but previously had abnormal cervical cancer screening. So that is kind of the overview to how we prevent and diagnose cervical cancer early. So what are some of the barriers to preventing cervical cancer? We kind of talked about the main development and something that has been highly effective in preventing cervical cancer is the HPV vaccine. But HPV vaccine rates are still only at about 65% or 2/3 of teenagers who fall into that schedule. Some research has demonstrated that that is because a lack of knowledge, concerns about safety of the vaccine, beliefs about personal risk of HPV and cervical cancer. So some people may not believe that they're at risk of HPV and therefore cervical cancer, or that their children might not be at risk of HPV. But like I said before, it is super common. And if you're ever going to be sexually active, your chance of getting HPV at some point is about 75%. There have been lots of safety studies on the HPV vaccine that has shown that it is highly effective with minimal side effects, but there are still some concerns about that. And there's also always, to any medical treatment, concerns about insurance coverage or concerns about cost. And then when it comes to screening, some of the barriers that we see are a lack of knowledge about the screening tests or who needs it and when they need it and how to get it. Modesty, it has historically required a pelvic exam with a speculum exam. Patient discomfort kind of on the same, in the same vein, that those two things can kind of contribute to patients declining recommendations for a PAP or HPV test, or not going in to get one. And there's still provider discomfort for some primary care providers who don't feel as comfortable with the speculum exam. So sometimes patients are finding themselves needing to see like an internal medicine doctor for a lot of their screening or tests related to diabetes or high blood pressure, things like that, and then seeing a gynecologist as well. There's also some discomfort in particular populations, which we'll get to. And then again, just the beliefs about their personal risk and concerns about cost. So, do we see disparities in cervical cancer? Absolutely, we do. We see disparities in rates of screening and rates of HPV vaccination, and we see disparities in rates of the incidence or how many cases there are of cervical cancer. So, this is a graph that shows the incidence in by race in the United States, by race and year. So this blue circle line is non-Hispanic white populations, and their rate is about 7 per 100,000. Thankfully, cervical cancer is getting rarer and rarer in the United States, but in certain populations, the incidence is actually going up. So this green triangle line is one of the lines that's going up, and that's our non-Hispanic American Indian and Alaska Native groups. And there's also a higher rate of cervical cancer in Hispanic, which is this blue triangle, and non-Hispanic Black, which is the orange individuals. We see similar trends in mortality due to cervical cancer. And that can be because of what happens before diagnosis or after diagnosis. So there are so many things that come into play when it comes to what contributes to mortality from cancer. And one of the biggest things is stage at the time of diagnosis. So how advanced that cervical cancer is. And when caught early, it tends to be more treatable because it's in an earlier stage. And so that's why things like prevention and screening are so important. There are some pretty unique populations in Minnesota when it comes to cervical cancer, as well as the United States. Sorry, my computer has a mind of its own right now. But some of the populations that I have been learning about and doing some research in are immigrant and refugee individuals, transgender and gender diverse individuals, as well as individuals experiencing incarceration. So some of the unique things that can impact cervical cancer care in immigrant and refugee populations. A big one here is differences in knowledge and understanding. There are some research in Somali populations in Minnesota that they don't even really have the words for pap smear or cancer or cervical cancer. And so that we don't have great rates for cancer in immigrant populations. Things are tracked more on race rather than on immigrant or refugee status or country of origin or birth. But we do know that some of the countries where we have immigrant and refugee populations coming from, those countries do have higher rates of cervical cancer. Just like I think I said at the beginning, that cervical cancer does have a higher worldwide burden than it does in the United States. Because of the trauma experiences that immigrant and refugee populations have undergone, that can contribute to their comfort and willingness to undergo pelvic exams. Sometimes anatomy can be different, especially we see this in our East African refugee populations, that they've had female genital cutting, which can lead to provider discomfort with performing pap smears. Different religious and cultural beliefs can impact things like modesty, and there's some data that shows that cervical cancer screening rates are higher with female providers or gender concordant providers. And then there's another thing that is a barrier in these populations is just generally a lack of regular contact with healthcare providers. In transgender and gender diverse populations, gender dysphoria can contribute to discomfort with pelvic exams. Providers can have discomfort with individuals that are transgender or gender diverse, just maybe not knowing the guidelines or not feeling as comfortable doing patient-centered or trauma-informed exams and care, and also hormonal treatment. So people who have cervixes who are taking testosterone, it can make it harder to do a pelvic exam because of the changes in the vagina. It can also mean that the specimens are actually inadequate, especially when it comes to pap testing, but the HPV testing can help with that a little bit. And then I've spent some time working with individuals experiencing incarcerations, and this is a group that has higher rates by far of HPV, cervical precancer, and cervical cancer than the general population. They're less likely to have received the HPV vaccine and less likely to have adequate cervical cancer screening. One thing about incarceration is that for places that have good access to medical care, it's often a good time to catch people and provide that cervical cancer screening. But it is often done outside of the guidelines because there's just not great continuity of care, and there's major barriers to follow-up care because of that lack of continuity. Incarceration is often only for a short time, and it's not always easy to connect them for those next steps on the cervical cancer prevention and diagnosis process after they leave their carceral setting. So what are things that are going on in Minnesota to help overcome these barriers? There is a statewide quality improvement program for providers to help improve vaccination rates. Minnesota's SAGE program is a breast and cervical cancer screening program that provides free or low cost cervical cancer screening and diagnostic services if the tests are abnormal to people who don't have adequate insurance to access these things, and then it also helps them get referred for treatment for abnormal testing. And then there's ongoing research in some of those higher risk populations. So one project that has been going on that one of my mentors has been working on is specifically with the Somali population, and integrating the self-testing into their primary care visits. This can help overcome a lot of those barriers, especially if there isn't enough access to providers of the same sex or gender, or just discomfort with a pelvic exam. Time in those preventative care visits can also be a barrier. So having the patient do the self-testing can help move the visit along a little bit. They have done a lot of work really trying to understand, listen to the community members and the providers that work with them to help make this a really nice option for them. And the project that I'm working on opening is expanding this to the transgender and gender diverse population. We don't have good numbers on their cervical cancer screening rates, but there is some general data that they're not up to date because of those barriers that I previously discussed. So we're going to look at some of those numbers and then see what offering them the self-testing, how that helps improve those numbers, and see if we can get any more information on how surgery and hormonal care for transgender and gender diverse patients affects their HPV and cervical cancer risk. And then other future directions that I see as important to improving cervical cancer prevention and diagnosis and treatment is just continuing to build these ongoing community partnerships and bringing the community members into our research planning, so that we know that we're asking the right questions and know what it is, really getting to the bottom of these gaps and these barriers. And then I think also figuring out how community and public health programs can fit well within the guidelines and be a little bit more integrated with the medical system so that it's easier to transition patients from more community-based screening and prevention tests to the appropriate follow-up or treatment that they need in the more traditional medical system. So those are some of the things that are in process and on the horizon. And hopefully we just keep cervical cancer care has continued to improve in the United States for most groups, but not everyone. So we want to continue on that trajectory and then continue to work with the populations that are experiencing the worst disparities when it comes to cervical cancer. I think that's all I have, and I can take questions. Maybe I'll stop sharing.
Thank you so much, Dr. Wise, for your engaging and extremely informative presentation. I mean, it's so inspiring to learn how some of your work is addressing barriers in cervical cancer prevention and promoting equitable care. So now we'll transition into our Q&A session. So please submit any questions that you have. This is your time to engage directly with Dr. Wise. And if some of you have attended previous fireside chats, you know that it is not a fireside chat discussion without setting the mood with our virtual fire. So we're going to get that started before we dive into our questions. So I see a few questions have been submitted, so we can start with some of those. There is one question that was entered during your talk, Dr. Wise, that asks you to talk more about why women over ages of 45 are not able to receive an HPV vaccine.
Yeah, that's a great question. You know, the FDA approval process is complicated and involved and takes into account like the risks and the benefits and kind of the cost effectiveness as well. And a lot of the reason is because patients over 45 are either have some natural immunity to HPV based on exposure over their lifetime, and are generally less at risk, kind of depending on their sexual practices, maybe more likely to be monogamous. But that being said, you can get it after 45. It's not, the risks aren't greater after 45. It just may or may not be covered by insurance, and it may be a little bit more challenging to find a provider who's kind of willing to go outside of the guidelines.
Thank you for your insights. On a related note, there's a question submitted about Pap smears and why they're not recommended for women ages 65 and older, and especially for cancer survivors.
Yeah, if you've had cervical cancer, then that has a whole different set of follow-up that is, I'll leave to the more experienced oncologist to speak to at a different time. But for other types of cancer survivors, like if there's higher risk of cervical cancer based on that, like previous pelvic radiation or something like that, you know, it can be an individual case-by-case discussion. Again, some of those risks of HPV or the natural immunity to HPV, the risks go down and the natural immunity go up with age. And one of the reasons that we do less screening now than we did before is because our screening techniques are better, and we know that extra screening can lead to unnecessary follow-up, which can cause harm. Those procedures aren't without risk. So that is like 65 is kind of where the risk benefit balance shifts a little bit. That being said, it's also something you can discuss with your provider, especially if you have a new sexual partner after the age of 65 and could have new exposure to HPV that you didn't have before. Since it's outside of the guidelines, it may not always be covered by insurance, but it's still something that you could talk to your provider about if it was something that you felt like you had a particular risk for.
Thank you for clarifying that. So on the topic of prevention, what is the likelihood that precancerous cells as detected through HPV screening will actually progress to cervical cancer?
Yeah, so we use different levels of precancer. There's truly only one level that meets criteria for precancer, and that's the third level. So we think more about what will progress to that third level, because without treatment, that third level, or CIN3 is the fancy word for it, it has a pretty high risk of progressing to cervical cancer and should be treated. So we use algorithms to determine if the precancers will turn into that precancer, and to know if we need to do further treatment or diagnosis for that risk of the precancer. Because once you get to that precancer, without treatment, it's a pretty high likelihood of turning into cancer.
Thanks for breaking that down. So obviously preventing these scenarios early and the HPV vaccine can play such a critical role. And we've had a few questions submitted already about the HPV vaccine. So what tips do you have for improving awareness about the HPV vaccination and increasing more girls and boys to be vaccinated?
Yeah, as an OBGYN, I don't have as much interplay with that age group, 11 and 12, but on the occasion that I do, it's something that we bring up. I think it's also super important to use people who have been affected by these illnesses to use their voices. So I talk to and either or people who are going through screening or know people. Eventually, most people know somebody who's affected by cancer and can use those stories. I talk to the patients that I see who have kids that are in that age group about the HPV vaccine. I think school-based programs and then continued, I think also just working with communities themselves and using ambassadors or within the communities to help people who have different reservations or different fears. There's reason why there is mistrust of the medical system, and we're always working on kind of repairing some of the breakdowns between the medical system and certain communities and continuing to work on that so that our recommendations continue to be as trustworthy as we feel like they are.
And I know there's a lot of incredible research and work that's happening at the University of Minnesota and with community partnerships too. So if you're interested, look into some of the work that Dr. April Wilhelm and Serena Zhang have been doing over the years. So there's a question about preventative tests and if there's similar preventative tests as the Pap smear for cervical cancer for some of the other gynecological cancers.
Yeah, great question. So, no, there's not. Vulvar cancer and vaginal cancer are a little more similar to cervical cancer, but they're way less common. So some of those things, like if you get into the cervical cancer, if you've tested positive for HPV and you kind of get into the cervical cancer screening and follow-up process, then we often will also just pay extra close attention to your vulva and vagina because that cancer also almost always comes from HPV. Uterine cancer is increasing in incidence and mortality in the United States, unlike most other cancers in the United States. And that is also an area where my research focus is why that's happening and what we can do to prevent that. Right now, there is no screening test for uterine cancer, so the main thing to do is be aware of the symptoms, which the main symptom is bleeding after menopause or heavy or abnormal bleeding. So that one's more symptom-based, whereas cervical cancer is usually asymptomatic, so it's important to have the screening test. Uterine cancer has an early symptom most of the time, but doesn't have a screening test. Ovarian cancer is kind of the unfortunate one where there's not a screening test and the symptoms are pretty vague and not obvious. So that one, there's been a lot of screening tests that have been researched and none of them have shown to be effective yet. So that's still an area where a lot of research is needed. I had that slide about stopping cervical cancer screening at the age of 65 or after a hysterectomy. But it is important to continue to see a provider for your pelvic organs. Like have somebody look at your vulva and vagina, not every year, but every couple of years. Have somebody, ask you about those symptoms of ovarian or endometrial cancer. Make sure your family history is up to date, and if you need genetic testing. Cervical cancer is not a family history-based cancer because it's 99.7% of the time due to HPV, but other gynecologic cancers can be inherited. So that's important to know too.
Thank you for highlighting that, also for just making sure that everyone is aware of what some of the signs and symptoms are for some of the other gynecologic cancers, and to just make sure that you are keeping up with your preventative services and also seeing your gynecologist regularly as well.
Or a primary care doctor who feels comfortable with gynecology.
Yes, or your primary care provider on an annual basis. So there have been some questions about how you envision or just how might sampling for HPV improve prevention and screening efforts.
Yeah, I think right now, what I'm hoping the immediate effect will be is that it will just get more people to feel comfortable coming into the office for their cervical cancer screening, knowing that they don't have to have a speculum exam or pelvic exam. And that, I mean, the PAP, when we collect those cells on the PAP, it is uncomfortable. It causes cramping. A Q-tip in the vagina is more comfortable. And I'm hoping that we can, that knowing that that's an option at your provider's office will get more people into the office. I think eventually, hopefully, you know, as we continue to figure out how more population-based and public health efforts can get these screening tests into the community and connected with appropriate follow-up care. I know that that's somewhat taken place in the colon cancer screening world, and we can probably take a note from their book now that we have these self-testing options once there are FDA approved options for having things done at home. But the important thing is just continuing to do that within the recommended intervals and seeking appropriate follow-up care for abnormal tests.
Well, apologies everyone that we're not able to get through all the questions. There were so many questions submitted, but we just don't have enough time to go through all of them. So apologies for that. But Dr. Wise, as we wrap up, we'd love to hear your parting thoughts. So what is one key message or actionable step you'd like to leave our audience with to help improve cervical cancer prevention and care in our communities, as well as on a personal, in their personal lives?
Yeah, I think it's important to just normalize that cervical cancer is a thing that can happen. HPV is super common. It's nothing that should be considered shameful, but can, and most of the time is just a virus that gets cleared, but does need extra attention. There are things to do that can prevent it, and there are definitely things that can be done to prevent its complications. So I think just continuing to normalize that and you know, discuss how common and prevalent it is. I think that there are many things in the OBGYN world that just don't get discussed as often as they need to be, and that because we work with such a sensitive area of the body can lead to some shame and fear, and we don't want that to happen. We're just here to take care of your whole self, but particularly your gynecologic organs.
Incredible note to end us off on. So thank you for the insights, and thank you so much, Dr. Wise, for answering these questions. And thank you everyone for submitting such thoughtful questions. We truly appreciating, Dr. Wise, just your insights. They've been truly incredibly valuable, and also just have helped us understand how we can reduce barriers and also promote health equity when it comes to cervical cancer prevention and care. So we have reached the end of our time, unfortunately, today. So thank you everyone for joining us, for engaging with us. And as we wrap up, we'd love to get your feedback on today's Fireside Chat. So when the session ends, a brief survey will auto-populate on your screen. So please complete it to provide your feedback, because it truly helps us improve and plan for future sessions. And after completing the survey, you will find a link to enter a drawing to win a prize pack filled with goodies from the Masonic Cancer Center as a small token of appreciation for your time. And lastly, mark your calendar for our next Fireside Chat in recognition of National Cancer Prevention Month on February 19th from 1 to 2 p.m. We'll explore the important topic of environmental exposures and their connection to cancer risk. And so make sure you follow the Masonic Cancer Center on all of our social media platforms for more details and also to stay updated on future announcements and events from the Office of Community Outreach and Engagement. Thank you everyone for joining us. I hope you all have a wonderful rest of your day and week. Take care.